Today I will be discussing the physiology of vestibular system. In this particular picture, I'm having many things. One, the location of the vestibular apparatus, and then their organizational aspect, and the person who described it and won a Nobel Prize for this vestibular system is Robert Rennie. He won a Nobel Prize for his discoveries in the vestibular system in 1916, and in his name there are at least two things here. One, Berenice chair, and then Berenice test. With this brief outline of this picture, here we have everything in this picture, a summary of the entire vestibular system in this picture. What is vestibular system? It is a sensory system that stabilizes our head and body during motion. Not only in motion, also when you are standing, that is your posture, or sitting, or anything making you upright positioning of the head. This is that system which carries the sensory information from the head. It is also known as the proprioceptor or proprioceptor of the head. We have the proprioceptors of the muscles and joints. Similarly, it is the major proprioceptor of the head. This system provides information about the motion. The motion, in the sense we have a linear motion, and this linear motion is again can be divided into vertical and horizontal planes, or also the angular motion. Oh, okay. This is the system that gives information about these aspects of the motion, whether it is vertical, horizontal, or angular motion. Also, it provides the spatial orientation of our head, especially the eyeballs in relation to space. By doing this, vestibular system is not only a sensory system, it combines with the motor system, because to achieve posture and equilibrium, it has to integrate the motor part. So that means it will integrate the motor parts, especially that parts of the our motor activity that governs the posture and equilibrium. We will not worry about this sensation as long as we suffer from this sensation. You are traveling to the Tirumala or any hill station, maybe in your wonderful car or a bus or any vehicle. Then what happens, what you observe, at one point or the other time, there will be so many curves and all those things. And when this vestibular system gets disturbed, and that we call it as a motion sickness, and we feel sick, we feel vertigo, we feel nausea, and we tend to vomit. I remember many times I visited Tirumala. Going up is wonderful for me, and even today when I want to come down from Tirumala to Tirupati, I will have a motion sickness. At one point or the other, I feel like throwing out. So that is what the vestibular system is. So that means the disorders of this system are associated with the vertigo, that is the moving of the head. Though you are not moving, the head appears like moving. And if you stand, you cannot stand in a stable manner. There is a postural instability. There is a motion sickness I described. In addition, the eyeballs roll, they move. move here and there. Their movement may be horizontal, vertical, or rotational. And with this severe oculomotor instability, the vestibular system operates. Another simple example I would like to give it to you. You are going to your hometown in a bus and you are trying to read some paper or some things of your interest, and see how difficult it is to focus on those things. That is what the vestibulo ocular reflex is working on. Having mentioned about the vestibular system in brief, let us move on. What are the parts of the vestibular apparatus? Now I use the word vestibular apparatus and where they are located. So the vestibular apparatus is located in the temporal bone, the petrous part of the temporal bone. There are three pairs of semicircular canals. These canals are again in the bony, they are bony canals. And then we have the membranous parts, the utricle and saccule. Here are the three. A represents for the anterior, the P for the posterior, and the H for the horizontal semicircular canal. So, and these are carried by the vestibular part of the vestibulocochlear nerve. This is the vestibular part of the vestibulocochlear nerve that reaches to the middle. So now these are parts of the inner ear present in the petrous part of the bone. These are tiny little the bony structures. Within these bony structures, we have the membranous components. So these bony structures are the semicircular canals and otolith organs. The semicircular canals, I have already said, anterior, posterior, horizontal. They sense the angular motion or the angular changes. Then we have another set of otolith organs. These are utricle, this is utricle, and saccule. They sense the linear, that is a horizontal or vertical motion. Moving further, you just see these components of the vestibular system. Again, I repeat, the component of the vestibular systems are basically two, 1 and 2. One is semicircular canal and 2 is otolith organ. These are semicircular canals, and this is utricle, this is saccule. And these are connected with the cochlea. This is the 2/1/4 turn of the cochlear ring. You can see that this is connected with the cochlea. The semicircular canals, they detect motion, and their abnormality gives you a sensation of a spinning. That means the entire thing is revolving around, a spinning sensation that is about the semicircular canal. Then otolith organs, this utricle and saccule. This is saccule here and this is utricle. I will just explain it in my subsequent slides. They are gravity detectors and linear acceleration detectors. Their defects produce a sensation of a tilt in the head in some or the other direction. Okay, so now the thickened endings here, this thickening and this thickening and this thickening, these are known as ampullae of the semicircular canals. And this bony part of the semicircular canal, if they are cut open, we have this membranous part. This is the membranous part. In this membrane, this is the membrane here. In this membrane, you have these organs, particular specialized organs are located. See here, this is the ampulla, this is the ampulla, and this is the ampulla, and this is ampulla, and this is known as the crista ampulla. This is crista ampulla. And in this crista ampulla, you have a gelatinous structure extending from here to this. These are known as a cupula. And these cupula are having a bunch of hair cells. These bunch of hair cells are located here, and they are the real hair cells, lesions. Okay. So that means I have mentioned about the ampulla, the cupula, then hair cells. And here, if you are looking at, this is a macula, this is a utricle, this is saccule, this is saccule. And this utricle and saccule, they have another gelatinous structures. And in this, the hair cells, over that, there is a gelatinous structure. And, over the gelatinous structures, we have the calcium carbonate stones, what are called otoliths. So, are also known as a statoconia, otoliths or statoconia. They are there, and these statoconia, they are having a greater density than the gelatinous structures. They exert the inertial effect on the hair cells, so that the hair cells are moved, or they will have a traction on the hair cells. This is about, and if you are looking at this, and this is the entire thing is a membranous part. Within this membranous part, we have the fluid filled with, and this membranous part, you can just see this, the orange red. This is the membranous labyrinth, and this membranous labyrinth, it is filled with the fluid, and this fluid is known as a endolymph. Okay, so now just giving back here in this situation, the utricle, this is utricles are located in the vertical direction, so they detect the vertical components. And these saccules, they detect the horizontal motion. So they are located horizontally. You can see that the direction of the motion in two or three dimensional structures. Just like that, you are sitting in a car, and suddenly somebody breaks up, brakes. What happens? Your head sinks up and your body reacts. That is one of the aspects. Or somebody is there, suddenly he accelerates. What happens? Your body is still in inertia, it's not in motion, and you suddenly jump into or move into. Similarly, what happens? You are going in an elevator, and in the elevator, when it suddenly takes off, you feel a particular sensation that is given by the utricle. I'm just giving you the examples when they are excited. Then moving on, so here I try to bring in you the vestibular system, the three semicircular canals. This is the bony canal. Here you just see this bony canal, and within this bony canal, we have the membranous labyrinth. So this is the orange one is the membranous labyrinth. Within this membranous labyrinth, we have the crystal. In the ampulla, we have the crista, and these crista, this is the crista here. This is the whatever the ampulla here. This is one of the ampulla, and this is what the inside is. This is the endolymph, and you have, this is the gelatinous cupula, is a gelatinous structure. In this gelatinous structures, you have a tuft of hair cells. Hair cells are located. Now, so now what this gelatinous structures does here, it is making as a barrier here. It is sitting as a barrier here. This endolymph is like this. This is going on. It flows. Any change in the direction of these semicircular canals will add a traction on this cupula. Cupula is a gelatinous structure, and this traction deviates and moves these hair bundles. We will see to it in the subsequent slides. Here is this the macula of the utricle and the macula of the saccule. The basic arrangement is the hair cells. Over that hair cells, we have the membrane, that is a gelatinous membrane, and over that are the calcium carbonate stones, what are called otoconia. Okay, so now move on. So here, what I have just given the information there in the previous slide, and in this the orange red membranous labyrinth. This is the membranous labyrinth, and see, this contains a fluid known as the endolymph. And this fluid, look here, if you are looking at this is continuous here, here with this utricle with the saccule, and further it continues with this canalis cochlearis. Canalis cochlearis that enters into the canal, the cochlea. In the cochlea, it makes the scala media. It forms the scala media. The composition of the endolymph is very rich in potassium. That is, it is similar to the intracellular. It is 150 millimoles of potassium. And the chloride, 130 millimoles, and sodium is 1 millimole. So very, very small amount of sodium. Okay, that is what and this is bathing the hair cells of the any of these vestibulocochlear system. So that means if this is the hair cell, on the top of the hair cells we have the scala, this endolymph. This is the bony canaliculi. You can just see that the cut portion of the bony canaliculi, and you have this the bluish green or green area around surrounding this orange layer, and this contains a fluid which is similar to extracellular fluid that is known as a perilymph. This perilymph composition, it is rich in sodium. This is rich in sodium, and it is having a very little potassium. Exactly the extracellular fluid position, the chloride 125. So this is the composition of the endolymph and perilymph, and this is very important to know the composition, because when we try to understand the signal transduction, this endolymph plays a vital role for the initiation of the impulse. Now here I just try to describe the endolymph that fills the membranous labyrinth. This is the orange one, is the membranous labyrinth, and also scala media in the cochlea. And the endolymph, as I have mentioned, it surrounds the apical part of the hair cells. Then perilymph is between the bony layer, this is the bone, and the membranous labyrinth. This is the membranous. This part is the perilymph, and this is present here, as well as in case of the cochlea. It is a composition of the scala vestibuli and scala tympani. And this has been the endolymph is being synthesized by the vascularis layer present in the cochlea. It's a continuous synthetic process, and that is being. So here is the oval window and round window through which the bony ossicles of the ear or middle ear are communicating. I'm trying to bring in you the hair cells. Like this is a cupula. This is a cupula, this is gelatinous structure, and these are hair cells, and these hair cells will just give the nerve, what is called a vestibular nerve. Similarly, this is one of the part of the utricle or secular, this thing wherein you have the hair cells here, and these hair cells having a gelatinous structure here, gelatinous membrane, over which we have the calcium carbonate crystals, what are called as statoconia. And the same thing here, they are, I felt they are a little more clear. This one I have taken it from my Guyton, and this one is from the Candle's Neuroscience. You can just see that this is the hair cell. And they mention about there are two types of hair cells. And these hair cells are having the supporting cells. These are the supporting cells because they hold these hair cells in place. And each of these hair cells have a tuft of hairs. You can see here, this is in the otolith organs. This is in the semicircular canal, and this is a cupula. And any traction that would push that either this side or this side, either in a clockwise or anti-clockwise direction. Here also, any traction of these stones, of calcium carbonate stones, move the or have the traction on these hairs. Again, we have a two type of hair cells here, what I have made, and these two type of hair cells. One hair cell, because these hair cells make a synaptic contact with the vestibular nerve. This makes a synaptic contact with the vestibular nerve. These are not continuity. So this is a synapse here. This is a synapse. A cup-like synapse is made, and this is a synapse, a single synapse. Type 1 are having a cup-like synapse. Type 2 have one type of synapse. So that means that this is a more really whatever the changes happening are detected because having a greater synaptic surface area. What happens when they are or when our head is rotated in a particular position? Say, for example, this is a posterior canal. This is a posterior canal, and this posterior canal it detects the head movement left to right on either side. So that means shifting it to the left or right, these get excited. So the fluid moves here, and if this fluid moves, and that is going on. One interesting thing about the semicircular canals. The semicircular canals are, we have three pairs. The left and right ear or left and right temporal bone, but they are exactly the mirror image on the other side. The left is the mirror image of the right. So exactly they will have, if something is going on here, see the other side will be having in the opposite direction. That movement of the fluid, if it is going in this direction here in the left, in the right it is going in the opposite directions. So that is because of the mirror image. Now this is about a posterior canal that I am trying to say, that a left to right shift. The superior canal. Superior canal is activated when we move our head for yes, like this. That means we are moving our head in this direction. You just saw me there. So this is the for the superior canal. Yes, yes, you can just see yes, superior canal. Yes, for superior canal. So then horizontal canal, this is horizontal canal. Horizontal canal is for head tilt, as we do for that nod disagreement. No, you don't disagree. So just like that. So that type of movement. So now I have said the horizontal for no, the superior, it is also known as the anterior, is for yes, superior for yes, inferior for no. So this horizontal for no, and posterior canal, also known as the inferior canal, is for a tilt. So this tilting of the head either in this direction or in this direction. Now, if you are looking at this utricle here, these utricle have two dimensions here, two dimensions. Some are placed in the horizontal plane, some are placed in the vertical plane. You can just see that. And these hair cells are embedded, and they will try to, these are the autocones, they are the statocones, these are calcium carbonate crystals. These will detect these changes, gravitational changes. And in case of a saccule, they will detect the linear motion, whether it is the horizontal or vertical. Now, having said that, I'm just trying to re-emphasize another interesting aspect of the semicircular canal. You just see this airplane there. So now I'm just trying to put you in that plane. So the pitch axis, the central one. So when the horizontal, when you shift this one, this posterior canal, you move this side or this side. If the plane is drifting this side or that side, this is a rolling axis. This is called a rolling axis. And the pitch is this direction. That means either the plane goes up or down. This is a pitch. This is a pitch. You can see the angulation. So this detects the pitch. So now this part, the rotation, this is rotating in this direction, say for example this direction or this direction, that is the horizontal. So I said the movement like this. So now with this three-dimensional component I am trying to emphasize, but again I will say that it for us very simple. The tilting of the head on either side by posterior canal, nodding of the head for yes is a superior canal, S for superior, and then the tilting of the head or the rotation of the head for no. This is what happens exactly in the horizontal canal. So this one, this side is the right side, and this side is the left side. You just see that. So when this is head is turned on one this side, you just see that the endolymph moves in this arrow, and the endolymph moving this arrow pushes the cupula. And if this pushes the cupula, it increases the discharge of the afferent nerve discharge in the vestibular node. Simultaneously, what is happening to the other side, on the left side, because it is going in the reverse direction. I said it is a mirror image. So it's going in the fluid moves in this direction, and this will produce the decreased discharge. The net effect is, our feeling is that this side is more. Because in the beginning, both are equally discharging. Both the nerves, the left and right nerve, are equally discharging. That is how our things are detected. Which side is greater, that detects the drift on that side. Say, for example, if you move this side, so the discharge here increases. So this is briefly about how the semicircular canals work. It's only horizontal one. I had taken example here. It can apply to the vertical, that is the superior or the inferior semicircular canals. Then about the maculae. These are sensory organs present in the utricle and saccule for detecting the orientation of the head in respect to gravity. They are located inside the surface in the utricle and saccule. These are small areas of 2 millimeter in diameter. They are called macula. The macula of the utricle lies in the horizontal plane and they plays important role in determining orientation of the head in the upright position. Conversely, macula of the saccule is located in the vertical plane, and the signals or orientation is lying down. It's in the lying down in the upright posture. So this is about this. Each macula is covered, as I have already mentioned, is covered by the gelatinous layer and embedded with small calcium carbonate crystals, what are known as statoconia. And in the macula, there are thousands of hair cells exist, and these hair cells project their cilia or cilia into the gelatinous layer. And this gelatinous layer is studded with those crystals. The basis of the sides of the hair cells synapse with the sensory endings of the vestibular nerve. I mentioned about all these. Here in this picture, I wanted to show that, so these utricle and saccule, we have a central part known as this red part. This is a striola. The hair cells are directed perpendicular to these, so on either side. Striola. So that means striola is a demarcating point between the hair cells where these utricle and saccule are located. In case of a saccule, say, in case of a utricle, these hair cells are towards this striola, and in case of a saccule, they are going away from the striola. I will maybe I will not go further here in this particular discussion. Now we come back. So now these hair cells, this is one of the hair cell. What happens to these hair cells? There will be one tall hair cell known as a kinocilium. The kinocilium, they have a multiple cilia, the kinocilium, and there will be more than 50 to 100 or 50 to 200 tiny little cilia in connection with this apex of this hair cell. This is the hair cell, one hair cell. There we have depicted only three components. Okay, three cilia. One is the tallest of the cilia, that is known as a kinocilium, and we have the small cilia, or the smaller one in height. These are stereocilia, and these tallest and the smallest, they are connected with the protein links. These are known as tip links. You can just see the spring-like structure. These tip links, they are connected. Now, these tip links are attached with the channels, cation channels, the mechanosensitive cation channels. And these cations, when this thing drifts in this direction, these cation channels open. These are mechanosensitive channels. These cation channels open. Once the cation channels open, because here is the part, this is filled up with the endolymph. Endolymph is rich in potassium. Of course, inside is also rich in potassium, but the potassium here is much greater than the potassium here. Inside, the potassium is around 130 millimoles, and outside here in the endolymph, it is 150 milliequivalents. Now, there is a greater potassium concentration in the endolymph. Now, the potassium enters the cell. Once the potassium enters the cell, it produces a depolarization. And this depolarization opens up this voltage-gated calcium channel. This is a calcium channel present in the lateral and basilar region of the hair cell. So that will open up the calcium channel. Now the calcium channel opening enters into the arrival of the calcium, and this arrival of the calcium induces the vesicle associated activation of the vesicle associated membrane proteins, or the VAMPs, and that in turn releases the transmitters present, or the vesicles present here, and these contains the transmitters of the glutamate receptors, and they release the transmitter, and these transmitters excite the synaptic contacts here with the vestibular nerve. Okay, so now having said that, I just read the motion detecting receptors of the vestibular, are the hair cells. This is the hair cell. They operate as below. The push is, suppose this push is this side, that is kinocilium, that the stereocilia depolarizes. If this is pushed, this opens. Suppose this is pushed on this side, the opposite side, that it closes the channels. Normally, there is some amount of opening of the channel, which either opens more or closes. So that means that produces a hyperpolarization. Now this depolarization or hyperpolarization are the things ultimately results in the activation of the 8th cranial nerve. So now the calcium influx, as I have shown, then potassium influx through the voltage-gated channel, then potassium outflux for repolarization. Because once it is depolarized, it's a repolarization takes place from the movement of the potassium, because the calcium entering, the potassium is driven out. That is how the electrophysiological dynamics of these hair cells. Now, just to explain whatever phenomena I have said, here is the hair cell. This is moving in this direction. This will depolarize, release the large amount of transmitters. So this is the transmitter here, and this transmitter activates. This is the 8th nerve, vestibular nerve, and it increases the activity of the vestibular nerve. Here, the number of spikes per second is 180 spikes per second, and that is increased. So that means there is an increased vestibular nerve activity. And this is the part when there is no movement. So at the resting stage, there is some amount of continuous tonic activity. This is 90 spikes per second. One interesting point about the vestibular system are functional even at rest. They are continuously sending the impulses. Even when you are sleeping, so the information about our body location is being sent to the respective centers. Suppose if you were, if there is an earthquake or something, or somebody moves you, so you are getting disturbed. So then you are you detect that change in the location. And another part, opposite to this depolarization, what happens? The movement of the kinocilium, this is kinocilium, in this direction towards the stereocilia. So it will close these ion channels or the tipplings, and that would hyperpolarize. So what I have mentioned, this is a pushing from the stereocilia, and this is a pull. So that means they pull it, so that a push-pull like mechanism that operates, that would try to monitor the eighth nerve or vestibular nerve activity. Now, what these activities, where these activities go? So that means these activities are carried by the vestibular nerve. That is the signal transduction, what I was trying to talk about, is happening in the hair cells, and they will go to the vestibular nerve. And this is the, in the vestibular nerve, we have the Screpas ganglion. And from here, it will go to, some part is go to the vestigial nucleus. And because some part is directly going to the vestigial nucleus, you just see that. So the vestibular nerve, so this is going to the vestibular nucleus. Now vestibular nucleus is having 4 nuclei. So 4 nuclei: superior, inferior, lateral, and medial. So vestibular nuclei are divided into superior, medial, lateral, and inferior parts. The superior and medial part, the superior and medial part, so these are connected with the collicles. This is the collicular system, where it receives their visual inputs, and it is connected with these, all these oculomotor nerves. That means the 3rd, 4th, and the 6th cranial nerves. So now they will make the contact with the ipsilateral and the contralateral aspects of the oculomotor or the motor nerves of the eyeball. That is the 3rd, 4th, and 6th cranial nerves. So either on this side and the opposite side. So this is one side, it is known. From here, that will reach to the thalamus. And from thalamus, that is the VPL, ventroposterolateral nucleus of thalamus, and then it will reach to the somatosensory cortex area S1. That is what I have mentioned here. Now, having said the superior and the medial nucleus, another interesting thing about the superior and medial nucleus, they are, that means semicircular canals are relayed here in this area. The lateral and inferior nucleus receives input from the otolith organs. And so the utricular component is connected to the lateral and inferior nucleus, and they are, most of the utricular fibers reach to the colliculus. So you just see that through this. So that means the lateral and inferior receives this otolith organs, the utricle and secule. Okay. So now, in addition to these, the vestibular system or vestibular nerves directly relay into the vestigial nucleus of the cerebellum, and even to the flocculonodular lobe of the cerebellum. The flocculonodular lobe of the cerebellum. That is what the connection and where they end up. So they will go to the colliculus, they will go to the thalamus, and they will go to the cortex. I just mentioned about the entire relay. Here is the muscle. These are the posture controlling muscles, and these posture controlling muscles, this is the medullary nucleus. So this medullary nucleus, superior, lateral, inferior, and the medial nucleus of the vestibular nucleus. Now, this superior and the lateral nucleus, this is receiving input from the semicircular canal. Can you see that? And now this semicircular canal sends information to the oculomotor nucleus, that is the nucleus of the 3rd, 4th, and the 6th cranial nerve. And here in the caulicle, they have been there are converging information from the visual and auditory inputs, so that the location of the eyeball is being adjusted accordingly. So now this becomes a part of the vestibulo-ocular reflex. This becomes a part of the vestibulo-ocular reflex, wherein the eyeballs moves as we move our head. And one side, this is the extraocular muscles, and it happens on both sides. So then this is after having been said about the semicircular canals, and we have the saccule and utricle, and saccule and utricle, they will be here in the lateral and inferior nucleus. This is a lateral and inferior nucleus. Okay, so from this lateral and inferior nucleus, some of the part will go to the colliculus, because some part, especially they go to this thing, and some of these lateral part receives input to the cerebellum. They will receive input from the cerebellum, and also they will give input to the cerebellum. So that means they become a part of the cerebellar, deep cerebellar nucleus, that is the vestigial nucleus, that is from the vermis, and for the flocculonodular lobe. For the flocculonodular lobe, they act as a nucleus. They act as a nucleus because they don't have a nucleus. The vestibular this nucleus has been utilized by the flocculonodular lobe. Now, what do they do? So they will send inputs down. Most of these utricle inputs go down to the postural muscles, and some of those reflexes goes up for the visual eye field. So now, after describing this, I will say that hair cells does the signal transduction carried by the signal generated is carried by the vestibular nerve, and this is the vestibular ganglion, that is a Scrappa's ganglion, and this from some part of this thing will reach the cerebellum without going through this thing. And vestibular nucleus have four pairs: superior, medial, lateral, inferior nucleus, and the superior and the medial are connected to semicircular canals. The lateral and inferior are connected to the utricle and saccule, and they are partly they involve flocculonodular lobe and the flocculonodular lobe and vestigial nucleus of the cerebellum. They are also connected with that, and part of the information also reaches to the colliculus, primarily from the superior, medial, and the secular component, and then the cerebellum is also involved, and the cerebellar outputs also make the spinal cord downwards, and the part of is the superior and medial, they reach to the thalamus and for the processing. Now, what are the functions of the vestibular system? One, it's a proprioceptor of the head. That means it tries to give a spatial orientation of the head in relation to body. That is the vestibular writing reflex, or in relation to space. The vestibular system provides the sensation of the head and body position in motion. So that means when we are moving, how the body and head are going together. Is there any lag? So this type of sensation is also by the vestibular system. Now, there is no meaning for the vestibular system if they bring the eye movements along, because if you are trying to shift your direction of the head motion, and if the eyeballs are not moving, what happens? If the eyeballs are looking there and your head is moving there, what is called? That is called strabismus or a squint. So they don't obey. So you are moving the head and the eyeballs are not moving. That is a squint. So that means for eye movements, they are important. The vestibular system is important because they try to gaze, they try to focus, what is called a vestibulo-ocular reflex. So then It's a coupler of the sensory system. This position sense, the proprioceptors, and it also joins with other proprioceptors of the body and couples it with the posture and equilibrium. Thus, I have mentioned it is a coupler, sensory motor coupler, and it is necessary for gravity and balance. Okay, and it is necessary for equilibrium. Okay, when I'm talking about motion, I missed the motion in terms of the linear motion, vertical motion, angular motion. These are all the functions of the vestibular system. The outputs of the vestibular systems are integrated with the other proprioceptors I have already mentioned, because they cannot stand alone, because they have to take the body along. And when other sensory inputs are not in equilibrium, that means there is a conflict with the vestibular system. Vestibular signal seems to act as a reference point. The vestibular system acts as a referral point, so that the other bodily postural signals they just try to equate with that. Unexpected conflicting inputs from the vestibular system can result in a vertigo, nystagmus, and motion sickness. This is about the processing. The processing takes place in the cerebellum, that is in the brainstem, in the colliculi, in the somatosensory area. So those things are all coupled. Now, what are the various reflexes associated with the vestibular system? I was making a passing remark on the vestibulo-ocular reflex, that is the stimulation of the vestibular system will carry information to the muscles or to the nuclei of the ocular muscle cranial nerves. That means a third, fourth, and sixth nerve. And that will produce the contraction or movement of this thing that is known as a vestibulo-ocular reflex. The vestibular writing reflexes, so these are again the inputs from the vestibular system, because they carry the information about the position or location of the head in space, and they will go to the colliculus and to the midbrain. They will be operating for the writing reflexes. There are what are called tonic labyrinthine reflexes. These are tonic labyrinthine reflexes or continuous information from the otolith organs. They are carried about the gravity. So this will be happening through the vestibulospinal reflexes. So now there are the vestibulocerebellar reflexes. So these vestibulocerebellar reflexes are operating or trying to derive the cerebellar outputs utilizing from information from the vestibular system. These are the reflexes associated. Now, I'm just trying to say that the vestibular system is involved in a balance and posture, coordination of head and body movements, and in fixating the visual image on fovea. Fovea is the most sensitive area of the retina. This is what is vestibulocular reflex. So ask yourself why text is readable when your head is moving, but blurred when book is moving. You just try that. Sit back and see. If your head is moving, because when you try to read, the head is moving, the text remains constant. If the text is moving, you have that very peculiar feeling. So now, the transduction I have already mentioned. I will not bother about the transduction here. The signs and symptoms of the vestibular system. This is another important thing. So the derangement or the disorders of the vestibular systems are associated with the vertigo. Vertigo means rotating. The entire world revolves around you. It's a very peculiar feeling, and this is vertigo. Loss of balance or disequilibrium or equilibrium abnormalities. Nystagmus, jerky movement at the eyeball, nausea, because this vomiting center is located around this area, the vomiting and the giddiness. These are the signs and symptoms of the vestibular system. Now, briefly, I will just read about the vestibular disorders. The vestibular balance disorders are ninth most common symptoms. The first one may be pain, fever, and other things which make you to visit the doctor. Mostly they involve the elderly persons, and they come with the balance problems in terms of the vertigo, dizziness, or a lightheadedness, or a motion sickness. Vertigo is a prominent symptom of this disorder. Vertigo means what we call it revolving around. And it is the disorder of this vestibular system. There's a labyrinth. Now, the disorders of the vestibular system, I just mentioned here a few of them. I will just quickly go through these things. Benign paroxysmal positional vertigo, the Meniere's disease, because these are short note questions, the motion sickness, the labyrinthitis, migraine associated vertigo, weightlessness in space. Now, I briefly mentioned about a benign paroxysmal positional vertigo. Once I happened to suffer from this thing, and when I was lying in the bed, and suddenly I felt that everything is revolving around me. So now, this type of thing happens even in a normal individuals. Sometimes, maybe maybe in elderly people. It is the most common type of vestibular disorder, characterized by episodes of a vertigo that occur with a particular changes in a body position. That means you are turning over in the bed or bending over. So that precisely happened to me, and it is because atoconia, that is calcium carbonate stones, which are located on the utricle, they separate or dislocate, and they enter and get lodged into the canals, semicircular canals, and the cupula. And when these crystals come and touch the cupula, they will stimulate the cupula, and you feel revolving. So that is the possible mechanism of explanation. This causes abnormal deflections when the head position changes in relation to gravity. So this is a benign paroxysmal. Benign means without any damage. Paroxysmal comes in attacks, and positional vertigo, benign paroxysmal positional vertigo. There is no treatment, and you allow him to stabilize. If it is severe, then surgical intervention may be required. Then Meniere's disease, this is another short note question. It's a disease, this disease is an abnormality of the inner ear causing vertigo and severe dizziness, tinnitus that is ringing in the ears, fluctuating hearing loss, and a sensation of a pressure or a pain affected the ear lasting for several hours. See, look at that, around 12 per 1,000. That means 1 person per 100 will have this Meniere's disease. It is diagnosed most often between the ages of 30 and 60, and it affects both male and female equally. Symptoms can occur suddenly and recur daily and very rarely. Hearing loss is also there, but it is transient. But sometimes it becomes permanent. The pathology or pathophysiology involves because of the inflammation of the vestibular system that increases the fluid, the endolymph, and this endolymph pressure makes the membranous labyrinth to rupture and allow the leak of the endolymph and into the perilymph, and they mix together. And this is the region of the Meniere's disease. The surgical intervention is to close that leak. Now, the motion sickness, I just read through this thing: nausea, blood pressure changes, sweating, pallor, vomiting, that are well-known symptoms of motion sickness. And maybe many of us have experienced it one or the other time. And it is produced because of the excessive vestibular stimulation, and because of the conflicting information. The symptoms are probably due to the reflexes mediated via vestibular connections in the brainstem and the flocculonodular lobe of the cerebellum. Okay, the space motion sickness, because the nausea, vomiting, and vertigo are experienced in astronauts. They have also having a similar things develop when they first exposed to the microgravity situation. For that reason, they often wear those gravitational suits. For this motion sickness, you must be knowing that NTist means help, because the antihistamines are the vestibulosuppressants. They decrease the excitability of the labyrinth and block the conduction, and they will relieve. The motion sickness is commonly prevented by the use of the antihistamines or scopolamine. Scopolamine is a cholinergic receptor antagonist. Now, the nystagmus is another thing. It is a jerky movement of the eye, start and end of rotation. It is a reflex that maintains the visual fixation on stationary points while body rotates, not initiated by the visual impulses. So it is not the visual. It is within this. It is starting from the vestibular system. When rotation starts, the eyes moves slowly in the direction opposite to the direction of the rotation, maintaining the visual fixation. Suppose if I am moving this thing and then this maintaining of the visual fixation is the vestibulo-ocular reflex. When the limit of this movement is reached, eyeballs quickly snap back to the new fixation point. So that means if I am rotating my head like this one is trying to move this thing, and he reaches there, suddenly it will move this thing. We will not appreciate that thing. The slow component of the rotation is the pursuit movement and the saccadic movement. The slow component of the movement is by the vestibular part. The quick component is from the brainstem collicular part. Nystagmus can be horizontal, can be vertical, can be rotational. The direction of the eye movement of the nystagmus is identified the direction of the component or a displacement of the cupula of the semicircular canal. The nystagmus can be congenital, that is inherited at birth, or acquired. This acquired nystagmus is due to the damage of the semicircular canals, the flocculonodular lobe of the cerebellum, or damage to the vestigial nucleus of the cerebellum. The vestigial nucleus is located in the vermis. Also, the nystagmus can be seen in the stroke, the multiple sclerosis, head injury, brain tumors, etc. So, some drugs, anti-seizure drugs, alcohol, sedatives can also cause nystagmus. A very brief note on this thing. I have gone through very quickly. Now, vestibular tests. There are. I have mentioned 4 of them. The clinical testing for nystagmus, that means look for nystagmus. Clinical testing for a body positional equilibrium, that is also a test for a vestibular part. The calorie test, I will describe subsequently. Benign chair test, the photo I had shown, the Benign, who is the Nobel Prize winner, he designed a chair in which he wanted to test each part of the semicircular canals in a particular position. Just that the chair is located and the chair is rotated in a particular axis, and are trying to detect which of the semicircular canals are affected. I will not go into the details of the Benign test. Now, the calorie test, because this is a short note question, I am just giving you. The nystagmus can be used as a diagnostic indicator for integrity of the vestibular system. Here, what we do, we irrigate the ear with the warm saline or a cold saline. That irrigation is known as a caloric stimulation, is used to test the function of the vestibular labyrinth. The warm or cold saline in the ear, what they do, they will cool or warm the endolymph. And this cooling and warming of the endolymph by instilling this will create a eddy currents in the endolymph, and that drives the motion and a cupular motion. The temperature difference sets up the convection currents in the endolymph with the consequent motion of the cupula, that is the cupula in the hair cells. In healthy subjects, warm water causes nystagmus towards the stimulus. So, for example, if I'm on the right side, towards that side, whereas cold water induces the nystagmus opposite here. So now you can for this calorie test you can have this mnemonic cows. What is that cows? Cold water nystagmus is opposite side. Cold water nystagmus is opposite side. Warm water cold opposite. Warm same. Warm water nystagmus on the same side. In case of unilateral lesion of the vestibular pathway, nystagmus is reduced or absent on that side. Suppose if vestibular pathway is damaged, so then you will not get this calorie test. So it becomes negative. To avoid nystagmus, the one caution, because sometimes we go to the ENT surgeon for irrigating over this thing because of the wax accumulation. During that time, we should avoid the nystagmus, vertigo, and nausea if the ENT surgeon uses or irrigates the ear canals with the cold or warm fluid, so that that would be dangerous. Maybe he should use the body temperature. In summary, vestibular system is a sensory system that governs the posture and equilibrium, consists of three semicircular canals and two otolith organs. Semicircular canals detect the angular motion, otolith organs detect the linear motion either in the horizontal or vertical direction. Composed of these either semicircular canals or the otolith organs, their basic unit is the hair cells. These hair cells have a cilia, what are called kinocilium and stereocilia, which are covered by the gelatinous structure, either cupula or macula. In the macula, we have those calcium carbonate stones known as autoconia, and they exert inertial effect on the hair cells. Any movement of these, because they are having a greater density, that would produce a traction on the hair cells. Hair cells, we have mentioned, it has a large one is a kinocilium, the small stereocilia, each one are connected with the tip links, and the movement of the kinocilium, the movement away from the stereocilia opens up, depolarizes towards the stereocilia, closes it, the hyperpolarizes, and increases or decreases the vestibular nerve activity. Impulses from the vestibular nerve are relayed into the medullary vestibular nuclei. There are four distinct nuclei: superior, medial, inferior, lateral. Superior and medial are supplied by the semicircular canals, the inferior and lateral by the otolith organs. Inferior and lateral are connected to the cerebellum and the spinal cord also. The vertigo, nystagmus, nausea, vomiting, postural instability are the manifestations of the vestibular disorders. I just made a summary of the vestibular system. If it were to come as a short note, you shall be able to write all these things. What I do is the assignment: semicircular canals, otolith organs, utricle, saccule, calorie test, Wiener syndrome, functions of the vestibular system, vestibular ocular reflex, Benign chair, signal transduction. Okay, these are my reference books. The Candles, Neuroscience, I have referred the Dighton and the genomes, and of course the Samson Wright is my base book in which I have mentioned. Okay, next class I will talk about the physiology of decorticate and decerebrate lesions. That means I will try to look into the CNS lesions and their effects. CNS lesions and their effects. Okay, thank you.